Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Keith Michael.
Thank you, and thank you all for coming. I'm just going to jump right in, and what I'm going to start with is a video that I hope will put in perspective what lumbar stenosis is and what reasonable expectations are for treatment and how it affects your life. This is actually one of our patients here from Duke Raleigh.
My name is Mike Cole. I work in an auto parts aftermarket distribution company. I'm a senior merchandise manager. I came to see Dr. Michael because I had a pain down the left side of my leg, and it went down around my knee and around my ankle and down through my feet, through my left foot. I've had this pain on and off for 7-8 years. To live with chronic pain, especially the pain that I had going down the legs, where it wasn't always there. It might go away for 2 or 3 months and then suddenly reappear. When you're in pain like that, it becomes a focus of your whole world. I know my job performance was suffering because you either take pain pills or you wince and close your eyes and suffer the pain quietly, but it affects your whole lifestyle. Well, my experiences with the staff at Duke have just been wonderful. There's always some trepidation and some fear and some anxiety, and Dr. Michael was very thorough in explaining the procedure and what he was going to do and what I could expect in recovery and what I could expect after recovery. But it gets down to the people that deliver your meal. They were on time and they were courteous. Everybody made my stay as pain-free as could be. And they were very pleasant to talk to. Very understanding, very, very understanding of pain level. They don't want you to hurt, and you don't want to hurt. So we're all working for a common goal. Some of the things I look forward to post-op and when I am healed is getting back out on the golf course. I am not the world's best golfer. There are two kinds of golfers, pros and everybody else. And I'm one of the everybody else. But the golf course is just a wonderful place to be, and it's very, very hard on your back. If you watch any of the PGA Tour professionals, most of them suffer from painful back injuries, so you really torque your back up. I don't hit it that far or that long, but I do get a full turn, and I'm just anxious to have that feeling of hitting a pure, solid golf shot again. I love to walk, and I have a little dog that loves to walk with me. And he seems to take 10 or 12 steps for every one that I do. But we'll go 2 miles, and he'll come home and get some water and lay down and go to sleep. I'm still ready to go. What I would want to tell people who are considering spine surgery is talk to the people at Duke. Get them to explain to you what the procedure is, what the outcome expectations are, and then don't worry about it. Just show up. They'll take care of everything else. You just do what they tell you to do. Follow their directions, and you'll be a different person. I would like to share with everyone else the experience that you get when you wake up in recovery and the pain is gone. I know I was groggy and I was on a morphine pump, but I could tell the leg didn't hurt. My she said, it's good to see you smile again, because for several months I couldn't smile. It hurt to walk, it hurt to sit, and I just kind of grimaced. And now I'm smiling again, I'm pain-free, I'm no longer on pain pills, so there's clarity. It was just the best thing I could ever do.
So I love that video because I think it highlights the important things about spinal stenosis, and that's the dog and golf. And I know you think I'm joking, but that's really what this problem is about, is taking away the things in your life that you love. It's not a problem that kills you. It's not a problem that paralyzes you. It's a kind of problem that makes your quality of life poor. And down to the little things like taking your tiny dog for a walk. And that's what I hope to talk to you about today. So let me tell you what you won't hear. And you might not believe this first one after watching that video, but this is really not an infomercial. I'm not here to... You're talking to the surgery arm of spinal stenosis, but I'm not here to sell you on surgery. I'm here to talk to you about what the problem is. You're not going to hear about lasers. A lot of patients ask me about the Laser Spine Institute. There's nobody at Duke that uses lasers for spine. It's a great marketing campaign. I won't say much more about lasers. The other thing you won't hear about is a lot of scientific jargon. I took out all of the fancy medical words, I deleted all of the data and the literature, and I just put it in plain terms, I hope, so that it'll be simple to understand. What I do hope you get out of this talk is what lumbar stenosis is, what causes the problem, how does it affect you on a daily basis, how does it manifest in your life, and what are the treatment options. Surgery is one of them, but that's for very few patients. There are many other treatment options long before we ever get there. So if I'm successful at the end of this, what you'll understand is the why, the how, and the when for how to manage your spinal stenosis. So let's start simple. Stenosis. Whenever I throw that word around in clinic, people always ask me, well, what does that mean? Stenosis just means tightness. And there's a million kinds of stenosis in the medical world. There's pyloric stenosis in your stomach. There's carotid stenosis in your arteries that carry blood to your brain. And then there's lumbar stenosis. So literally what stenosis means is tightness around the nerves. What about lumbar? So lumbar is your low back. It comes from the Greek lumbus and loin, which if you're a meat cutter, that might mean something to you. The loins are there in the back. Those are the paraspinal muscles that support the lumbar spine. And in our picture here on the bottom right, it's the yellow part of the spine. It joins the rest of your thorax to your pelvis. I'm going to give you the down and dirty in the anatomy of lumbar spine. And there's really only 4 things you need to know. They're the bones, the nerves, the discs, and the muscles. And all those are interrelated in the process of spinal stenosis. We're going to start with the easiest, the bones. The primary role of the bones in the spine is to provide structure. The way I think about the lumbar spine is like a tripod. And that's why I have the picture of a tripod in the bottom left and a 3-legged table. If you've ever been to a restaurant and you've had a 4-legged table where you're trying to shove a matchstick under there or fold up a napkin, you know that the 4-legged table isn't as stable as a 3-legged table. It's the most stable construct, and that's exactly how the lumbar spine was designed. And the legs of the tripod are the big disc platform up front, and then these 2 small joints in the back called facet joints, or zygapophyseal joints. Some people call them Z joints for short. But that's the 3 legs of the tripod. 2 joints in the back that are symmetric, and 1 disc up front. Why do you need that system? Because that allows motion. If you've had a kid with a tricycle, you know you can tilt that tricycle forward over the front wheel. That's the same way you can get motion in your lumbar spine. And then the most important part of the spine, besides holding you erect and providing structure and stability, is to protect the neurologic structures. All the nerves or the spinal cord, depending on what level we're talking about, are housed in this circle. And that's going to become a big focus for the rest of this talk, because the nerves are the problem, or the bones are the problem and the nerves are the victim. But either way, they're interrelated. So what about the nerves? Well, the nerves go the entire length of your body. They start in your brain. This is an MRI scan of an entire body. So the nerves start here. They run all the way down the spinal cord. The spinal cord actually ends here, right at about the start of the lumbar spine. And then it turns into nerve roots. There's a big difference between spinal cord and nerve root. We're not going to talk much about spinal cord today because that's a problem of the neck and of the thorax. And that gives you a whole different set of symptoms than spinal stenosis. Lumbar stenosis pinches the nerves. If I pinch your nerve, it hurts. It's a horrible, neuropathic, inconsolable pain. And it goes right down your leg in a very specific distribution. If I pinch your spinal cord, it's painless, but you get paralyzed. So this isn't a problem that paralyzes you. It can give you weakness occasionally, but mostly what it gives you is pain in your legs. And that can take a number of forms that we'll talk about. So the nerve roots, once the spinal cord ends, it branches into a bunch of nerves that look like shoelaces on an MRI that you'll see a couple times tonight. And that's called the cauda equina, which means the horse's tail, because it literally looks like the tail of a horse, the fibers, the hair. People often come to the clinic and tell me their problem is with their sciatic nerve, and they wonder where that comes off. Well, the sciatic nerve is just one of the many nerves that is built in the cauda equina. So the sciatic nerve is literally this nerve, and it's a conglomeration of a number of nerves that come out of the lumbar plexus. From L1, L2, L3, L4, L5, S1, they all contribute to the sciatic nerve, which runs down the back of your leg. It's not always the nerve that's involved in a lumbar stenosis. You can have pain in the front of your leg, which is the femoral nerve. There are many nerves. The sciatic is just the most famous. It's sort of like the Coca-Cola of soda. It gets all the attention. And these nerves carry both motor and sensory function. If you pinch the nerve and you get weak, that's because you have a motor deficit. If you have bad pain or numbness in the distribution, that's a sensory deficit. So these nerves all run together. The discs. So the disc is in between each bone, and what it provides is a shock absorber to cushion some of the action that comes up through your legs when you walk. And the other thing it does is allow motion. And we talked about that motion before between each of the joints at each of the levels. Unfortunately, discs don't last forever. They do eventually wear out, but that's the natural part of life. There's two parts of the disc to know about. I usually think of it like a tire or like a jelly donut. And you have an annulus on the outside, which is your hard, thick rubber radial. And on the inside, you really either have air, but in this case it's more a jelly like a donut. And that's contained. That annulus holds everything in, and the shock absorber is the central nucleus pulposus on the inside. A disc herniation, which is not usually the cause of lumbar stenosis, but a disc herniation is when this soft nucleus herniates out through, almost makes a hole in the rim of the tire, and explodes out and pushes on the nerve. Disc degeneration. A lot of patients are told they have degenerative discs, and they don't know exactly what that means or if it's related to their problem. What a degenerative disc looks like on an MRI is this black disc, and that's caused by desiccation, which is the water leaving the disc. It's drying out as it ages. After it starts to desiccate, it loses its height and it starts to collapse. Degenerative disc is a natural part of life. I tell all my patients in clinic that degenerative disc is like balding and gray hair. It happens to everyone in different phases of life, and everybody handles it differently. And you're probably looking at me wondering the same thing. Well, I used to have a lot of hair. A whole lot of hair. And you can see how I'm handling it now. I just cut it shorter and shorter and shorter. And that's how degenerative disc is. And the reason I make that analogy is because if I do an MRI on a 25 to a 40-year-old male who has no back pain, who's healthy, active, normal, I'm going to see a degenerative disc about 40% of the time. And obviously that's not a cause of any pain because they're totally asymptomatic. So the presence of a degenerative disc clinically means nothing, in fact. Until that disc gets so degenerative that it starts to push on a nerve, it doesn't really have any clinical significance. Now, it can be a source of back pain, but it's not the source of the nerve compression until it progresses to the degree that you get arthritis and hypertrophy that presses on the disc. The muscles. They're the last piece of the quorum. What the muscles do is support the bones. They offload the joints that are arthritic, that have pain and pressure, and they support that core. And they can help your posture, and you're going to hopefully understand by the end of this talk why posture matters in lumbar stenosis. What does lumbar stenosis look like? A lot of people have back pain, a lot of people have leg pain. How do you know if yours is lumbar stenosis? The quintessential classic presentation of lumbar stenosis is this idea of neurogenic claudication. If you go home and type that in Google or you look that up in your dictionary, what it's going to say is to limp or be lame secondary to nerve compression. That doesn't mean anything to me. Let me tell you what it really looks like. It looks like Mike Cole. And that is, you're fine when you're sitting down. You're fine when you're at the grocery store leaning over the cart walking. But the second that you stand up and you stand erect or you try to demand from your legs and walk, be it upstairs, up a hill, just from the bedroom to the bathroom, you get a progressive buttock pain. It starts up high in your buttock and then it migrates slowly down your legs. Now it may do just one leg. It may do both legs. It may do the back of your legs. It may do the front of your legs. That all depends on where the nerves get pressed. It's my job to figure out where that is. It's your job to tell me where it affects you so I can understand where that is. And then the more you walk, the worse it gets. Until eventually you can't take it, you sit down, and it goes away. And the clock resets. Now, sometimes that's associated with back pain. Lumbar stenosis itself is usually the claudicating pain that starts at your belt and goes down. The back pain is usually from a different problem, probably a problem causing the stenosis. Now, it can be neurogenic. It can be caused by a pinched nerve, but typically pinched nerves are leg pain. It could be weak muscles. That can cause back pain. It could be degenerative discs. It could be weak bones. It could be a fracture. It could be arthritis in the facet joints. That's the cause of the back pain, which we'll try to make a separate entity from the lumbar stenosis, which is a product of the tightness around the nerves. So sometimes the best way to understand what something is to understand what it's not. So if you've ever had a friend or you yourself experienced a pinched nerve, that is a lumbar radiculopathy in the medical world. What that means is one specific nerve has pressure on it, and you can come into clinic and you can point out a pain where you can follow it right down. You can say, the pain comes right here, goes right down the lateral part of my calf and bites me in the ankle. That's because that specific nerve, the L5 nerve, has something pinching it. That something can be a disc herniation, that nucleus pulposus pushing on that nerve. It can be a stenotic tight hole where the nerve comes out, the foramen. It can be a facet cyst. There are a number of causes that can pinch that specific nerve, but that's very different from that claudicating leg pain and buttock pain I get when I walk. That's unrelenting, miserable nerve pain that you can't get away. And it's very specific in its distribution, and it's usually from a focal lesion, like this picture, where you have one nerve. All the nerves look fine, and then there's a disc pushing on the one red, angry nerve. Remember, neurogenic claudication with lumbar stenosis is different in that you get rest relief when you sit down. It goes away when the demand lessens, which is sitting or standing flexed forward, and it's worse with standing and walking. So what else is it often confused with? Vascular claudication. So there's that word claudication again. Remember, that just means to limp or be lame, and this time it's from a problem with perfusion. So the difference in a vascular claudication, that's somebody who's not getting good blood flow to their legs, is that they'll tell the opposite story. They'll say, when I get up to walk, I get numbness and pain in my feet. And the more I walk, it comes up to my calf, and then it comes up to my thigh, and the only way I can make it go away is to stand still. So standing still is enough. They don't have to sit down. That's very important. And by the end of this, you'll hopefully understand why. The other difference is those vascular patients have bad pulses. You can often see they lose their hair on their legs. Their toenails look funny because they don't get good blood supply down to their feet. To contrast that to the spinal stenosis, neurogenic claudication, remember it's opposite. It starts in the buttocks, goes down the legs. Standing doesn't make it better. Standing makes it worse. You have to sit down or flex forward to make it better. Your pulses are good, and your neurologic exam is actually usually normal. You usually don't have weakness with spinal stenosis. You just have progressive pain with activity. So if you understand the difference between these two and why they're different, you can go hit the refreshment stand for about 10 minutes and catch back up with me, because I'm going to explain why that part is. And then you can go teach medical school, because that is it's a complex problem. So I'm going to explain it to you in economics. Okay? I'm sure you all had economics at some point in your education, and they talked to you about supply and demand. So vascular claudication, neurogenic claudication, these are supply and demand problems. And here's the demand. The nerve requires nutrients, and those nutrients are glucose, they're oxygen, they're red blood cells, they're all the things it needs to work. The demand is you. The demand is you wanting to get up out of the chair and walk to your car, to go up the stairs, to walk to the beach, to do all those things. That's the demand end. Okay? The supply is the blood bringing the nutrients to the nerves. So let me bring bring economics now to healthcare. And let's talk cardiac economics, and an example you all probably know well. So a heart attack. What happens in a heart attack? You try to do something that you're not used to doing, typically. Shoveling snow, going for a long walk, walking on the treadmill. You get chest pain. The chest pain is a sign that there's a problem. What is that chest pain caused by? It's caused by a supply problem. So you have an artery that when you were 20 looked good. Now that you're 65, it doesn't look so good. They can't get as much blood, they can't get as much oxygen to their heart that they need, and especially when they put the demand on it. The demand is making the heart beat harder and faster to supply whatever activity you're trying to do. So what do? They do a cardiac cath, They figure out where the problem is, and they either put a stent in there or they bypass it. So they repair the supply. Your demand doesn't change. The demand is your activity. The supply is getting around that blockage. So the reality is that in a heart attack, the problem is the muscle cannot get enough energy. The supply is deficient to allow it to contract to pump the blood. And the pain comes from the muscle who's starving. It's just like a hungry muscle who's begging for food. In reality, it's ischemia that's causing the pain. Let's forget that for a second. Let's just imagine it's a hungry muscle. The hungry muscle is what causes the pain. We believe nerves are exactly the same. So when you demand from a nerve, he gets hungry. He is starving for nutrients. And if you demand too much from him, then he gets angry and he starts yelling at you and makes your legs hurt. That's the fundamental premise of neurogenic claudication and spinal stenosis. So let's talk about what that actually looks like in the spine. So there are two prevailing theories. You think we're advanced in medical care because I can show you an MRI that shows you your discs and your nerves in your brain, and yet we can't even figure out some of the most fundamental things like what causes back pain. But we also can't figure out which of these two theories is right. But I think it's probably a combination of the both, so let's talk about them. One theory of spinal stenosis is that the problem is tightness around the nerves, and it's the mechanical pinch that makes your leg hurt. That pain is generated from the mechanical compression. It gets better when you sit and flex forward. We'll talk about why that relieves the pinch. It gets worse when you stand up and lean back because that increases the pinch. The piggyback theory to that is that it's ischemia, that you don't get enough blood to the nerve when you're trying to do things like walk. So the stenosis, the tightness, impedes the blood flow, just like in the heart, and that results in inadequate nutrition to the cells, the nerve cells. The nerve cells they're hungry, they're starving, they scream out, and that causes the pain that goes in your buttock, just like the cardiac muscle that hurts when you have a heart attack. How can I prove to you that's true? I could show you some of the science, but I don't know that it's worth it. Let me talk to you about it in real terms. Consider the clinical symptoms of lumbar stenosis. So it's worse with walking and standing. What's walking? Walking is increasing the demand. When you're standing still, you're firing those nerves periodically to keep your body balanced, but when you're walking, those nerves are firing. So it's increasing the demand when you walk. That's why the claudicating symptoms get worse. Why does standing hurt at all then? Well, that hurts because of the mechanical compression. Because when you're standing, that canal narrows, the nerves get pinched, and that creates that claudicating buttock pain. Why does it get better when you flex forward? Almost every neurogenic claudicating patient will tell you, I can walk a block before I have to sit down, and yet I go to the grocery store and I can walk up and down every single aisle and do my shopping. And you say, why is that? And they say, I take that grocery cart, I lean right over it like this, and I walk right along. And that's because when they flex their spine forward, it opens the canal, buttock and legs are relieved. There's actually a medical term called the grocery cart sign. My residents love it when you guys are in clinic and they say, this patient has the grocery cart sign, they told me about it. And patients often will. So let's understand why standing and sitting changes everything. So I made a little diagram here. So we talked about how the nerves live in this canal in the bones. So we're going to talk now about the interface between the bones and the nerves. So I want you to imagine that we're looking at two levels here. We have the blue level and the tan level, and they're overlapping. So we're looking at overlapping holes. It's as if I cut you in half. Now I'm looking down. These are your nerves here. The little speckled dots are your nerves. This is an MRI, axial cut. They float in this white fluid, the spinal fluid, cerebrospinal fluid, CSF. Okay? So this is normal. That's what the opening should look like, and there are two levels there. So I'm going to superimpose those levels, and in these examples, the space for the nerves that's available is where the two colors overlap. So here, there's a huge space for your nerves to live. In lumbar stenosis, you don't have such a big space. So this is one level, this is the next level, and so the nerves have to transit in between in that shape that looks like an eye. Okay? Now here's what happens when you take a patient with lumbar stenosis and they flex forward. So you have the two levels overlapping. It looks like an eye. Watch what happens when they flex. It transfers one level forward. So suddenly the space available for the nerves is huge and the nerves are happy. That's why sitting works. That's why sitting relieves the leg pain. That's why flexing forward over the grocery cart works, because it opens the canal where the nerves live. Now the opposite of that is if you take that same patient with lumbar stenosis, they've got the eye-shaped hole for the nerves, and you have them extend, they make the hole tighter. And that's what happens when you stand up. It narrows that canal where the nerves live, the leg pain comes on. And then you start walking, you create more demand on the nerves, pain worsens. How do you make it better? Flex forward, open that hole, get the blood in, feed the starving nerves. So patients always ask me, what causes the stenosis? And that's not a simple answer because it's a little bit of everything. So if you remember the normal level that I showed you, here's the hole where the nerves live. Look at the different things that can encroach on that hole. So here we have a large disc bulge from a degenerative disc. That contributes to narrowing the canal. You have a hypertrophic facet. Hypertrophic just means big, from arthritis. It's grown big. The body makes things grow when they get arthritic. That's its response to pressure. And what happens is eventually that starts encroaching on the spinal canal and pinching the nerves. And it can come from the front and the back. It can come from the discs and the hypertrophic facet, and suddenly your canal looks tiny, just like those overlapping circles I showed you. This is what spinal stenosis looks like, tightness around the nerves. Sometimes it's caused from some other things that are less common. This is a cyst. And it's not a tumor, it's actually an outcropping of joint fluid that herniates out and it displaces the nerve. So normally the nerve sac should go all the way over here, but instead it goes like this and it follows this cyst. All those nerves over on that side, which is actually the right side, have been pushed over to the left. They've been displaced and that canal cross-sectional area has decreased. That's stenosis. So it can be caused by discs, it can be caused by cysts, it can be caused by hypertrophic facets, it can be caused by innumerable things. One of the other things it can be caused by is instability. And this matters because this changes how we treat it. So if you notice in this case, the bones line up perfectly in the back right here until we get to this level. I'm going to outline that for you so it's a little bit clearer. So I drew a line on the back of each vertebral body. And this is a nice, gentle, sweeping, beautiful curve. And here's a big step. It's translated forward by about 1 centimeter. So we call that in slang a slip because the bone has slipped forward. The medical term is a spondylolisthesis. But fundamentally what that does is that takes those two overlapping circles, makes them tighter. So that instability can contribute to spinal stenosis. And you can see that in this MRI. So when that bone slips forward, you get an hourglass here where the nerves are trying to pass through, and that's the stenosis. Treatments. I'll usually take, and this is even the surgeon talking, I will tell my patients never take a pill when you can do therapy, never take an injection when you can take a pill, never have a surgery when you can have an injection. And that assumes that each one of those works. But the theory is do the least risky thing. And when that stops working, when your quality of life becomes bad enough, then move on to the next one. Because there's an increasing escalating risk with each one, a reasonable risk, but certainly there's very little risk to therapy. There's very little risk these days to medications, with the exception of some side effects. But start at the bottom and work your way up. Most patients will never get to the surgery. So the simple things. Anti-inflammatories. There is good evidence in the literature that anti-inflammatories are an excellent treatment for spinal stenosis. They don't change the tightness around the nerves. They don't change that at all. There's only one way to change that, and that's surgery. But there's a lot of ways to make the nerves happier about living in that tight environment. That's what anti-inflammatories do. They break that inflammatory cascade where the nerve gets angry, the nerve swells, that hole that was tolerable before is now extra tight, and the nerve is angry. And if you can calm that cascade down, block that inflammatory pathway, the nerve will quiet down and your leg pain can get better. And if you think, I've tried Motrin, I've tried Advil, I've tried ibuprofen, there's still 6 you haven't tried. So there are plenty of other things, other medications that if you don't tolerate one, your doctor, your primary doctor, me, anyone, whomever's caring for your back and your legs can try other medications. So that's the first line treatment. There are even special anti-inflammatories these days. So these are general, the NSAIDs, they block all of the COX pathway. There are COX-2 inhibitors like Celebrex, which is more expensive but more selective if you have trouble and can't take the NSAIDs. And the other anti-inflammatories are steroids, or a Epidural dose pack. Maybe you've had one of those before, a 7-day taper of steroids. And that's almost like if NSAIDs are the handgun, then corticosteroids are like the bazooka. But they have a little more side effects than NSAIDs, so you don't need that maybe. You start at the bottom and work your way up. Muscle relaxants. Sometimes you can get spasm and cramping in your calves and in your thighs when you have spinal stenosis. There are a lot of things you can do to relax those muscles with medications. Now, unfortunately, the side effects are it doesn't just relax the muscle that's spasming, it relaxes everything, so you get sleepy. But sometimes that's worth it if your spasms are bad enough. Nerve pain medicines. So gabapentin and Lyrica are two of the common medications for nerve pain. And the way these work are to mediate the neurotransmitters that are released. They basically take the volume of a nerve that's really angry and they turn it down. They don't hit the power button, they don't turn the nerve off. They just potentiate the nerve so it's a little quieter than it was before. So maybe you still can feel the hint of the leg pain, but it's not bad. It's tolerable. Physical therapy. There's a lot of good evidence in the literature that physical therapy helps. And this is why. Because I showed you those overlapping circles, and I showed you if you can flex forward, it opens the spinal canal. So what is the solution? Everybody should have a grocery cart and we all just walk around bent over? I mean, that's a horrific solution, right? But what you can do is change the orientation of your pelvis. You can do things with the muscles to change the posture so that it opens the spinal canal. We're not talking about inches. We are talking about millimeters. These nerves are millimeters. If you make a millimeter difference in the spinal canal area, that's a lot to a nerve. And so small movements like this in therapy can have a big effect. And the theory behind it is opening that canal by changing the orientation of your pelvis and the lumbar spine bones, and then building that core muscle strength to allow you to maintain that good posture, which will allow you to increase your walking distance. So there's good science behind trying therapy, even though a lot of people think it may be less effective. It's not. Epidural injections. Obviously, these got a lot of press in the last year when there was contamination with a fungus. But I think of epidural injections the same way I think about driving a car and flying a plane. You know, you're safer flying a plane. Statistically, you're less likely to die in an accident if you're on a plane. Unfortunately, when there is an accident, it's usually catastrophic. But the accident rate in epidural injections is so small that you hear about it when there is a problem. But it's usually a treatable problem. So these are actually very safe. If you look at the statistical data for epidural injections, and I don't do any injections. I'm not giving you the infomercial, but I use them a lot. I send them to my partners who do them, and they have a big effect with a very, very low complication profile. And they've been around for a long time, almost 100 years. What they inject is numbing medicine and steroid medicine. And here's what each one of those do. The anesthetic, which is the numbing medicine, breaks the neural feedback. It just confuses the nerve. So the nerve is angry, firing, and it puts it on pause for a second, and it resets. And then it basically stuns the nerve, and the nerve wakes back up a little bit quieter and not quite as angry as it was before. That's an oversimplification of the theory, but that's what happens to the nerve. The steroid, remember we said, is the bazooka of anti-inflammatories. It takes the angry, red, inflamed nerve, and it calms it down. And this is an incredibly effective way to get the medicine where you want. Think about if I give you a steroid pill. You swallow it, it goes into your stomach, it's absorbed into your blood, it circulates through your entire body, and a couple of those molecules make it to that nerve that's way back over here. It's an incredibly inefficient delivery system. If you want an efficient delivery system, take the needle, put it right next to the nerve, and squirt all the medicine right there so it bathes the nerve. That's why epidural injections work. There are a lot of ways to do them. They're all done under X-ray. Sometimes they're done under CT scan, which is a more accurate way to do them, but that's not always necessary. Most of them are done under X-ray, and that's a perfectly good way to do it. And in fact, the majority are done that way. And I'm going to show you a couple images. Patients always want to know, what is it like getting an injection? Do I have to go into the hospital? No. This is an outpatient procedure. It's done in a clinic. It takes about 15 to 30 minutes. They ask you to hang out for 20 minutes to make sure you're doing well afterward. You should notice pretty immediate relief when they numb that nerve, and then it takes a couple of days for the steroid medicine to kick in. Once it does, it gives you pretty long, and sometimes lasting relief from the inflammation of that nerve. But they literally just roll you over on a bed just like this. They prep out one little area where they're going to put the needle in. That's a fluoroscopy machine right there. It's a little x-ray machine that he can look on this screen, and they get images like this where they can watch the needle. And this gray here is actually dye. They inject just a little bit of dye where their needle is to make sure it's in the right place, and so it's tracing out the nerve. That needle is right around the nerve, and so we can see it's in the right place because it's tracing out the nerve. Just like this is a CT scan, that's the needle coming in. That's their dye, and they're making sure it's in the right spot for the nerve. So it's an accurate way to get the medicine exactly where you want it, using guidance from imaging to deliver medication directly to the nerve. And just because you've had one doesn't mean you've had them all. There are so many different places to put the needle. Centrally in the canal, transforaminal out through the side where the nerve comes out. Block just one nerve. Do it at the very bottom in the caudal level. So if you see a physician who says, I want to try a different injection, it's worth doing because you might not have had that very specific one. In my practice, I use injections a lot to help make patients better. That's therapeutic, but I use them a lot for diagnostic value. If I'm trying to figure out what surgery to do on a patient and I want to know, is this nerve the problem, I'll send them for an injection to numb that nerve so that I know it gets better. So I know that if I free that nerve up, we'll have success. So injections are used for a lot of reasons, and they're very valuable. But how long do they last? Everybody asks me that. I don't know. I can tell you sometimes I send patients for an injection and they don't come back for a year. Sometimes I send them for an injection and they come back in a week. Everybody's a little bit different. Sometimes it's finding the right level. Sometimes it's how tight it is and how angry the nerve is. I can't tell you how long it'll last until you try. It is probably a true statement that serial injections last a little bit less each time, but not always true. Sometimes you need a couple to really calm down the nerve. So while a good question, I can't give you a steadfast answer. Most patients who need them regularly can get 3 to 4 a year. Excuse me. But there's no set time that these are intended to last. All right, now the last piece. You've tried everything else, and now you're thinking about surgery. I'm going to boil down surgery to 2 really simple things. There's only 2 types of surgeries we do in spine that are of value. Don't tell any of my partners I said that. They are decompressions, which is freeing up nerves, and they are fusions. And fusions are indicated when there's instability. So decompressions are indicated when you have tightness around the nerve that's either causing that severe leg pain or that claudicating, neurogenic claudicating buttock and leg pain we talked about. And decompression looks like a discectomy, taking out that piece of disc pushing on the nerve. Or it looks like a laminectomy with or without facetectomies, and all those are fancy medical words for saying taking away the bone and the ligament and the structures that are pushing on the nerves, freeing up the nerves, decompression. Fusion. There are a host of ways to enact a fusion. A fusion is simply taking away motion at a level. And remember, motion can be the enemy, because when you get arthritis and you still have motion, the arthritis causes those joints to grow, they get hypertrophic, and that's what pinches the nerves. So the theory behind a fusion is you take away that motion once you free up the nerves, and it prevents recurrence of the stenosis. Now, their ways to fuse include doing interbody fusions, which is putting cages in, and sometimes we go through the abdomen, sometimes we go through the flank, sometimes we do it all from the back, sometimes we do poke the screws through the skin. These, in the modern day, we can put cages in from the side through an incision about that big, using x-ray and nerve monitoring, and then we can turn you over and poke screws through the skin without making an incision. And that's a lot easier on patients, and it can have equally good results. But the fundamental thing that you need to understand is decompression and fusion. Not everybody needs a fusion. You probably need a decompression if you're going to get spine surgery, and we often do them together. So what does a lumbar decompression look like? Well, this is that MRI I showed you before. And it's basically taking away the tightness around the nerves, shaving off that piece of the disc, removing some of this hypertrophic joint, so that in the end, the spinal canal looks like this one, where the nerves are freed up. A lumbar laminectomy in a single level. I stole this as this was no pun intended, but an advertising coin on somebody's website. where they took their incision and they measured it to a quarter. Now, the size of the incision clinically doesn't matter. If I make a 2-inch incision on your back versus a 1-inch incision, you're not going to recover twice as fast with a smaller incision. It is like lasers. It is marketing to do this. So what you want is a successful surgery that frees up the nerves. It doesn't actually matter how big your incision is in terms of your recovery. Now, if we can do the same thing through a smaller incision versus a bigger one, yes, pick the smaller one. But that isn't the fundamental goal in all of this. So what a laminectomy is taking away that bone in the back so we can access the spinal canal and free it up. That's what it would look like if I cut you open and I move the muscles out of the way. That's what I would see. I would take away that bone. And you're fine. I take that bone away and you don't need it. You don't need anything covering up that canal. That's going to be just fine and those nerves are going to be all freed up. Leg pain will be better. If I look at you from the top down like we did on those MRIs, what it looks like is taking a trough out here so we can access those nerves and make sure they're all freed up. That's a laminectomy or a decompression. It can be done minimally invasively through a tube. It can be done through a small incision with a microscope. It can be done with an incision about 2/4 big. It doesn't matter how big that is. It doesn't matter how your doctor does it. They're all good ways. The literature says that doesn't matter if they do it through a tube, a tiny incision, with a camera, that everybody recovers at exactly the same rate. It's just a matter of personal preference and marketing and all of those things. What you really care about is a successful decompression. And the same applies for this. Now, fusion is a dirty word in spine clinic. I have patients come in and they say, I want anything but screws and rods. And they don't necessarily know what the screws and rods were, but they know somebody who had one and they aren't doing well. But here's what you need to know about fusion. It is all about the indication. So if I do a fusion for a black disc on an MRI in a patient with back pain, what I would tell that patient is there's a 30% chance your surgery will work. That's what our literature says, that a fusion for back pain for a degenerative disc has a 30% chance of success. How many people, if I gave you a 30% chance of success, would sign up for that? I hope you wouldn't. I don't offer that surgery because I couldn't handle a clinic of 7 out of 10 unhappy patients. So it's all about indications. The reason to get a fusion, and the literature supports that fusions are incredibly successful for instability, slippage of the bones, or instability that looks like a curve, a scoliosis. Those two reasons, if you get a fusion, in the first situation, a slippage of the bone and stenosis, if you have a successful fusion, meaning it heals and you free up the nerves, the literature says it doesn't matter how you do it. It doesn't matter if you go from the side, the front, the back, doesn't matter. 94% of the time, if you accomplish those two goals, patients themselves report good to excellent results. That's a lot better than the 30% who are getting fusions for back pain. So remember, you should only get a fusion if you need one. And you need one if you have instability. It's like getting a fusion and not having instability is like getting a new battery when the problem is your alternator. The problem is the battery's not getting charged. You can put as many new batteries as you want in there and they're going to keep wearing out. So remember, instability, listhesis, slippage of the bones, scoliosis, that's a curve. We talked about unfavorable results for discogenic back pain. So that's why you hear from people who had fusion surgeries that were unsuccessful because maybe the indications weren't as tight. So with good indications, screws and rods are essential. Let me show you some examples. So this is a patient. You see the instability here. This disc is collapsed and it's rotated. So if you look along the lines here, these line up nicely. This one right here is twisted. And this is where this patient had her stenosis. So we did this poking cages through the skin, 2 incisions on the side that were about 2/4, to use their example. Poked these screws through the skin. You can see we straightened out the small curve and the listhesis that she had, and by recreating that disc height, freed up the nerves. You can do that with a curve as well. So you can take a curve like this. This is a scoliosis caused by arthritis and degeneration. And you can put cages in from the side, poke screws through the skin, and you can straighten out their curve. And in straightening out their curve, you indirectly free up those nerves. And I'm just showing you a couple examples that happen to be poking the screws through the skin. But sometimes poking through the skin and poking through the side is not the best way. It's best to make an incision in the back, open it all up, and free it up by the traditional method. It's good to have all those options available so you know which is the best for your condition. Finally, cages. My father was in town a couple weeks ago, and we were talking about spine surgery, and he said, whatever it is, I never want a cage. And I thought, that's so funny. He actually has no idea what a cage is. He just knows he doesn't want one. But A cage can be a really valuable thing. A cage sounds barbaric, like it should hold an animal. What a cage does in spine surgery is it supports the bone while it grows together. So cages are often used to replace the disc. Remember, the disc is a motion segment. So if you slip the cage in, you pack it full of the patient's bone or something that makes bone grow, and you put it in there, that causes the bone to fuse together. That's the idea of a cage. It's a support for fusion. And they usually go in the front, and there's a lot of ways you can put them in. This cage is put in from the side. That's the ones that I showed you on the x-ray. This cage is actually put in from the back. We put it all the way in the back here at the front. These cages are put in obliquely from the back. There are a host of different cages that can be put in from different directions for different conditions. And cages can help fusion. They always ask, what are the cages made out of? Two things. In the modern day, most cages are made out of PEEK or titanium. PEEK is just a fancy plastic. It stands for polyether ether ketone. It's an inert plastic. That means your body doesn't react to it. You can't have an immune response to it. Your body cannot reject it because it's inert. And that's why we use it. And all it is a vehicle to support while the bone grows between. Recovery. That's the other thing patients always ask me about. How long will it take me to recover? Well, the answer to that is it depends on the surgery, and it depends on what you mean by recover. Sometimes what they mean is, when can I drive? Sometimes what they mean is, when will I have to stop seeing you? It depends on what you mean when you say recovery. So for me, in my practice, what I use is you can have unrestricted activity. That means skydiving, do whatever you want, jiu-jitsu, once the fusion is healed, if you're getting a fusion. And that, on average, takes 6 months to a year, depending on what kind of healer you are. If you're not getting a fusion, the recovery is markedly faster. So Mr. Cole, who's in that video, was about 6 weeks out from his surgery, and he was back to starting to play golf. If you're talking about independent living, most patients that begin, depending on what they're doing, are around 4 to 6 weeks before they're back to moving the way they were used to. With almost every spine surgery we do in the modern day, you're up walking the next day after surgery with the physical therapist. So it's all a question in how you define recovery. Driving. Most patients are driving by 4 to 6 weeks, again, depending on what kind of surgery they've had. So recovery is variable, and that's important. Mr. Cole made a good point of that in that video, which is that's something you should talk about beforehand so you have the appropriate expectations and understand what your recovery course is going to look like. So surgery, to summarize surgery, there's decompression, freeing up the nerves. That's a more simple, easy to recover from procedure that doesn't require any instrumentation, doesn't require the bone to heal. There's decompression and fusion, where we free up the nerves and then we make the bones grow together to stop the instability. And we can do that from the back, all posterior, traditional laminectomy and fusion with an incision, screws, and rods. We can do it with cages that we talked about, doing the cages from the back. We can do it with cages from the front. We can do it with cages from the side. You get the point, that there are a myriad of options, and this is where it's valuable to sit and talk to your surgeon about what's best for you. What is best for your condition and why? All right, before you fall asleep, we'll wrap it up. So lumbar stenosis, that's nerve compression from degenerative change. It presents with claudication. That's progressive pain in your back with activity. It improves with sitting and flexing forward. It's a demand and supply problem. This is not a problem that paralyzes you. It doesn't leave you with permanent neurologic deficit, typically. In its most severe forms it can, but that's extremely rare. What it does is it kills your quality of life. Takes you off the golf course, takes you out of the grocery store, keeps you from going to church, keeps you from going to your friend's house, and you gradually pick each one of those things away until you can't do them anymore. There's a lot of ways to treat it, and start with the simple ones. Medications, anti-inflammatories, physical therapy, epidural injections to deliver that medicine right to where the problem is. If all that fails and your quality of life is significantly limited, that's a time to think about surgery. And there's a host of types of surgery for very different indications. Make sure you're getting the right one for the right indication, and our literature suggests your outcome will be favorable.